Thank you very much for the invitation, Dr. Fawaz, and I wish to thank the organizer committee for this wonderful meeting. I was given the task to look into the long-term durability of the TAVR. What do we know so far? I'm a cardiac surgeon and also a TAVR implanter since 2011, National Guard, Riyadh. It always seemed impossible until it is done. And this was the first implantation of the TAVI valve by Creepier, and it was a dream to reality on the 16th of April 2002. I will take you through my presentation journey. I will try to give some insight on TAVI valve durability, what is in the name of fibrostatic valve deterioration, the change of definitions, and we'll give some data on SAVR fibrostatic valve durability, the comparison of TAVR and SAVR outcome comparison, what are the registry and the randomized trial so far said, and we will see what are the predictors of structural valve deterioration, and we end up with our take-home message. TAVI valve durability, it's a reality and expectation. The expectation and the long-term durability of fibrostatic valve becomes increasingly important as TAVR expand to younger and low-risk patients who they have a longer life expectancy. Durability is not only a procedure and prosthesis. There is a patients who we have to also consider. We have a long-term experience with the different prostheses of fibrostatic valve, and we have a long list and different companies introducing different types of valves from stented, porcine, bovine, and stentless, and so forth. And all of these have the advantage and disadvantage in terms of durability. If we talk about the transcatheter valve, we also have a menu of all different types of transcatheter valve. So what are available of data regarding the SAVR durability? We can see here there are a significant number of articles which shows their durability up to 14 years. And the available study shows that rate of freedom from structural valve deterioration is up to 85% in more than 10 years. Patient age at implantation is a well-established predictor of valve longevity. Other predictors of structural valve deterioration after SAVR has been reported to be renal impairment, smoking, arterial hypertension, diabetes, and metabolic syndrome. These are all data from long randomized and non-randomized studies for the last 15 years. If we look at the studies by Johnson et al. At the Annal of Thoracic Surgery in 2015, where they explanted 354 patients among 12,500 patients after surgical AVR. And we can see that the majority of the predictors of surgical implantation were young age, as well as patients who have smaller aortic valve who end up with higher postoperative gradient. We can see here from this graph that the age at implantation will be a determinant of the valve deterioration as the patient grows. In 2017, there was a need for change for definition of what is structural valve deterioration. Historically, definition of structural valve deterioration was based on the need for reintervention and valve-related deaths. However, presented on the TCT that there is a need for change the definition. So what is the need? They want to define the standardized definition of structural deterioration. And it was agreed between the European Association of Percutaneous Cardiovascular Intervention, European Society of Cardiology, and European Association of Cardiothoracic Surgery. The change was to focus on not only on structural deterioration in terms of calcification of the valve, the tear, and fibrosis, but also to include the non-structural, such as prosthesis, mismatch, valvular and paravalvular leak, thrombosis, and endocarditis. All these categories, from structural and non-structural, it should be considered in order to define that this patient has structural valve deterioration. They have agreed that echocardiography should be the main tool to assess and to follow up the patients and to come up with a morphological and hemodynamic parameters to define structural deterioration. In order to standardize this, we have to have a common standard to define structural valve deterioration. And there should be a clear distinction between structural valve deterioration as a pathological etiology and bioprosthetic valve failure, which is considered as a clinical entity. Furthermore, structural valve deterioration always cause irreversible dysfunction. Where are the other causes of the structural valve deterioration, such as the non-structural thrombosis and endocarditis, may be reversible. Structural valve deterioration may be the result of technical issues, and we have to appreciate that, and could be a faulty implantation. But when resulting from non-structural, such as paravalvular leak, it still qualifies as bioprosthetic valve failure. And they have agreed that echocardiography should be the main modality to develop and follow up on this assessment. If we look at this study by Barrett and et al., structural deterioration of transcatheter valve versus surgical aortic valve, and considered as the analysis of the Partner 2 trial, where they looked at the 5-year incidence of structural valve deterioration according to the new standardized definition, and they randomized it into either TAVR with XT versus SAVR and TAVR with SAPIEN 3 versus SAVR. What we have to look at here, that we have to appreciate that all the patients mean age over 80s, and they are significantly high-risk patients. And the primary endpoint was the incidence of the structural valve deterioration, related hemodynamic, or related bioprosthetic valve failure. What you could see from these graphs, that the 5-year Kaplan-Meier cumulative rates and exposure adjusted incidence rate of all-cause bioprosthetic valve failure in the whole cohort were higher in the X3 valve TAVR. If you look at the other graph here, you can see that the XT, which is the black color, the incidence is about 9.5%. And the SAPIEN 3 is 3.9, and surgery SAVR is 3.5. They also find out that the rates of all-cause bioprosthetic valve failure were numerically, but not statistically higher in the SAPIEN 3. In the SAVR cohort, most bioprosthetic valve failure were related to endocarditis. Therefore, the factors which were associated in this article with structural valve deterioration was young age, female, small size valves, and chronic pulmonary disease. The authors have concluded in this article of Partner 2 trial that the 5 years rate of structural valve deterioration were higher in the SAPIEN XT TAVR and not statistically different in the SAPIEN 3 TAVR compared with SAVR. The 5-year rates of all cause of bioprosthetic failure were higher in the XT and SAPIEN 3 TAVR versus SAVR. In the Sabian XT, the majority of the failure and the valve intervention were related to the valve deterioration, whereas in the Sabian tree, most of the valve failure were related to non-structural dysfunction and mainly related to paravalvular leak. Half of the biventricular of the bioprosthetic valve failures in the SAVR group and reintervention were caused by endocarditis. If we look at the TAVR durability in the registry, we can appreciate here that there are 6 registries: UK, the Dutch, the Durand, and Holy, and Etista, and these all studied the TAVR registry as we have seen in this graph. But these registries, they have significant limitation. The significant limitations that they address advanced age, high-risk profile patients with limited life expectancy. And that's manifested, as you can see here, in the all-cause mortality. The significant mortality in these all registries, up to 7 and 8 years of follow-up, this constitutes a major limitation on what can we come out of all these registries. This is another paper by Dodge et al., where they looked at beyond the 5-year horizon, the long-term outcome of high-risk and inoperable patients undergoing TAVR with first-generation devices. They have 214 patients underwent core valve and 86 patients underwent Sabian, and that's the study between 2007 and 2009. We can conclude in these studies where they reported an overall cumulative incidence of valve deterioration, 14.9% at 7 years, based on TAVR registry with first-generation valve. They also made a comparison between the self-expanding core valve and the balloon-expanded Sabian, which also performed, and it demonstrated a more favorable outcome with the core valve in terms of structural valve deterioration, with a significant difference between 22.6 in the Sabian and the 11.8 in the core valve. So what are the randomized trials saying in terms of outcomes? And I will look into the partner, the core valve, pivotal high-risk trial, and the notion. If we look at the partner 3 trial, where they looked at transcatheter aortic valve replacement with a balloon expandable valve in low-risk patients. And we can also see here that the mean age of all these groups are 73. They considered as a low-risk patients, and the overall frailty is not significant. And their echo finding that there were no difference between the 2 groups at 30 days and 1 year for the aortic valve area, mean and big gradient, in comparing TAVR and SAVR. Mild paravalvular leak at 1 year was higher with TAVR than with surgery, and 29.4 to 2.1. However, the limitation of the study that they excluded patients with poor transfemoral access and the bicuspid valve. And if we look at the risk of death, stroke, and rehospitalization, was considered as higher here in surgery, 15.1, and in TAVR, 8.5. Therefore, they concluded that among patients with severe aortic stenosis with low surgical risk, the rate of composite of death, stroke, or rehospitalization at 1 year was significantly lower with TAVI than with surgery. And this is the partner 3 trial. If we come to the partner 2 trial, where they look at 5 years outcome of transcatheter or surgical aortic valve replacement, and we can see that they have enrolled almost 2,000 patients. Most of the patients have intermediate risk with severe AS, The mean age was 81, and they are considered as a high risk.
Extra 2 minutes.
More patients in the TAVR group have at least mild valvular leak, aortic regurgitation. Repeat hospitalization and aortic valve intervention were more frequent after TAVR than SAVR. Moderate or severe valvular leak associated with an increased risk of death at 5 years. They did a very interesting landmark analysis where they looked at the outcome, the mortality between 2 and 5 years after the procedure, and there were a higher incidence of death and disabling stroke and death from any cause after TAVR than SAVR. They concluded in the partnered trial that among patients with aortic stenosis who are at intermediate surgical risk, there was no significant difference in the incidence of death or disabling stroke at 5 years. If we look at the Nordic aortic valve implantation notion, where they reported clinical outcome and durability of the bioprosthetic valve at 8 years after TAVR and SAVR, and TAVR using the first generation self-expanding Medtronic core valve, and SAVR they were using St. Jude Epic in 29% of the patient, Mosaic in 27%, and St. Jude trifecta, and mitral flow. And this is very important points that to address, because in this notion trial, they used 2 valves, which has proven to be having very significant valvular deterioration early. And we can really appreciate that the bioprosthetic durability study limitation of using these 2 valves has significantly limited the extrapolation of clinical and the echocardiographic outcome to other bioprosthetic aortic valves. And in the notion trial,
We'll give extra 1 minute.
Sorry. There was no difference between the estimated risk of all cause of death and the risk of all cause mortality at 8 years were similar between the 2 groups. I think I will come to the outcome of this data and randomized and the non-randomized trial. We have to focus on that patient-centered care is the outcome of all these trials, and this coincides with the recommendation of the guidelines. There's a very interesting review published in April 2022, focus on anatomic and clinical risk stratification and heart team. I believe that as I started with the patient prosthesis and procedure, we have to focus on a patient-centered multidisciplinary heart team to address these issues. My take-home message, current data from registry confirmed that in early and mid durability, there is no difference. However, we need to look for the long-term outcomes. Some see changes, they are, and others, the comment. Thank you very much for the opportunity.